as usual. Good morning, everybody. After that heavy meal that presented by Dr. Saab for hepatitis B and C, we are gonna go to the next hot topic, which is fatty liver, and it's gonna be presented from one of our experts in that field, Dr. Simon Beaven. So, Dr. Simon. Thank you. Pleasure.
All right, good morning. I knew I was in the right place when I pulled into the parking lot and I saw a license plate that said ascites. I knew this was the right place. And then, of course, it dawned on me, it's got to be Bruce Runyon's license plate, which it is. So you can't get that one. So just as Dr. Saab said, Nash is actually a disease that keeps on giving. It just tastes good as it keeps on giving. And unlike viral hepatitis, I'm a little jealous at this point, right? Viral hepatitis, we've kind of beaten. The NIH is not going to fund mechanistic work on Hep C because we've got great treatments. The same is not true of Nash. Okay, so I'm going to give you some updates here of what's new in the last year. We, like the obesity epidemic, we move slowly in this field. And it's not for lack of trying. There are thousands of people around the world trying to study this process. But what I want to re-educate you to or reorient you to is the idea that the liver is a central part of the metabolic syndrome. And you see here the 5 canonical features of metabolic syndrome. And underlying all of them is insulin resistance. Now, that could imply failure of the pancreas, but at some level, insulin resistance occurs even before the pancreas has failed. And behind insulin resistance, there's this chicken and the egg argument about, is it metabolism that's important or is it inflammation? And it's very difficult to tease those things out. And there are plenty of examples where you have a markedly obese patient with a high CRP, a high SED rate, high liver tests, and they seem to have systemic inflammation. That's been the dogma for years. But in fact, there are lots of examples of people who have no inflammatory markers and have nasty NASH, nasty fatty liver, and even cirrhosis from that. So I want to give you a sense of where people have come in the metabolic world, and especially in the pharmaceutical world, because while the 3 receptors you see listed here, you may never have heard of. They are natural endogenous receptors that your body has sprinkled about in your organs. You have a bile acid receptor. We're going to talk about that in relation to the Flint trial. You have PPARs, which are the master regulators of not only fat synthesis in the periphery, but also fatty acid oxidation in the liver. And you have endogenous cholesterol receptors called LXRs. And so if you weren't aware of it, you're already using drugs that actually affect 2 of the 3 of these receptors. Glitazones are PPAR agonists. Fenofibrate is a PPAR alpha agonist, and they've been in use for many years. Turns out ursodeoxycholic acid, ursodiol, is not an FXR agonist. It's a mimic of a bile acid, but it doesn't actually agonize that receptor. However, obeticholic acid, which I'll speak about in a little bit, is a direct agonist of FXR and has been tried directly in treatments for treatment of fatty liver. The LXRs you don't see chemicals on the shelf available that agonize LXRs directly. Although I would put it to you, that's probably going to change. It was feared that for years, despite tickling that receptor and getting improvements in cholesterol levels, you might actually get fatty liver and have hypertriglyceridemia. And so nobody ever had the chutzpah to try it. Well, the laboratory I used to work in just published a paper last year showing that in monkeys, over a long period of time, LXR agonism is actually beneficial for cholesterol and fatty liver. So there are paradoxic effects. Just like with Dolly the sheep, if you hadn't tried, you would never know. Okay. So it's important to remember that the liver is not the primary place to store fat in the body. Peripheral fat is the place to store fat in the body. But all fat gets exported from the liver and sent that way. So the liver is like Costco. Everybody ends up at Costco at some point, right? I challenge anyone here not to be in Costco at some point in your life. So there are lots of alterations in fatty acid metabolism in NASH, including an increased flux of lipids into the liver. That's the old story. Get obese, fatty acids flow to the liver. But just as important is the idea that the liver actually synthesizes fat itself, and it's still unknown what percentage of the whole body homeostasis that makes up. It's probably more than 40%. If you don't oxidize fatty acids in the liver, you're going to have impairment of removal of fat, so you're going to end up with fatty liver from that way. And then there's a host of basic biochemical reactions, including increased inflammation, oxidative stress, ER stress, autophagy, that have all been looked at. So there's many ways to slice it, but there are at least 4 major paradigms here for that. Our lab a couple of years ago demonstrated that quite clearly that you can shift fat out of the liver, you can look like you're an insulin-sensitive animal and have lots of inflammatory markers at the same time. One of about 3 models that actually demonstrates that inflammation doesn't necessarily mean you're insulin resistant. The paradox was that this animal actually had a defect in its pancreas, so maybe over the long term you might induce pancreatic damage. Again, the yin and the yang, you're always chasing the chicken and the egg. Okay. Just to remind you how lipids, if you're liver-centric, you're worried about hepatic insulin resistance. That's clearly a feature of progressive fatty liver and diabetes. And in this slide, diacylglycerols, fatty acids that come into the liver, impact insulin signaling directly. And so it's not important that you know each of those little boxes, but you should know that fats impair the signaling of insulin and lead directly to hepatic insulin resistance. The same argument actually can be made in peripheral muscle. You can have arguments in central nervous system, but at least in the liver, hepatic insulin resistance at some level is a direct perturbation of hepatic insulin signaling. What you guys want to know about are what are the treatments for Nash. This is a short list, it's not a complete list, and this list will continue to grow. There will be many compounds tried, and by and large, the medical management of obesity and fatty liver is a failure at this point. It's a failure. Diet, exercise, sleep, and alcohol reduction are critical components. They are components not necessarily for the treatment of the liver, they're components of treating the complications of metabolic syndrome like cardiovascular disease and dyslipidemia, which actually kills people, okay? The true treatment for obesity and metabolic syndrome that actually works over time with sustained real data across 20 years is actually bariatric surgery. And in 2015 at UCLA, we have a Medicare Center of Excellence. We call it COMET. We're seeing lots of patients. We're treating them with what we call metabolic surgery rather than bariatric surgery. The mortality rate is less than that of a laparoscopic cholecystectomy. It induces a profound weight loss and improvement in diabetic parameters. And this is not just our center, this is across the world. So the Swedish obesity study this last year showed in 20-year follow-up, the bariatric surgery had a 50% reduction in the microvascular complications of diabetes over 20 years. And in 3 years, you can see the same things in terms of cardiovascular disease and stroke. Medical therapy, nope. You get a little decline, but it comes right back up. So it's a really sticky situation. People have used glitazones and vitamin E, which I'll tell you a little bit about. And then there's that question mark there by the FXR agonist obeticholic acid. And if you've seen my talk in previous years, you might remember some of the other compounds on here, but now they've got lines through them because they either killed people like the GS9450 compound from Gilead, which induced drug-induced liver injury, or they just don't work. All right. I want to remind you that when you use a glitazone, pioglitazone or rosiglitazone to treat Nash, you are not actually targeting the liver. You are targeting that yellow stuff on the upper right corner. You're targeting the peripheral fat. And you will cause people to gain weight. That is the known and expected consequence of using a PPAR gamma agonist. But it doesn't mean that that weight gain is actually a bad thing. You've got to remember when you treat diabetics with insulin, the first thing that happens is they gain weight. But we think that's a good thing. We think that they're storing fat out in the periphery where they're supposed to do it. There are many issues with glitazones. They improve liver histology, but they've never been shown to reliably improve fibrosis. How long are you supposed to treat somebody with a glitazone? 50, 60 years? Are you going to treat a non-diabetic with the anti-diabetes compound? There are concerns around weight gain, fluid retention. There was a big thing about congestive heart failure and MI. The glimmer at the end of the tunnel here is that not all glitazones have equal anti-diabetic effects. So the pharmaceutical companies are actually still interested in them and still testing them for their effects in diabetes. What about vitamin E? You know, vitamin E has a storied history, and it was as good as pioglitazone in that Beaven's trial a few years ago for Nash. Well, if you look outside the liver GI world, you might remember that in cardiovascular disease, they tried it for atherosclerosis, and they had to stop it in the mid-'80s because more people ended up with heart attacks. So the cardiologists kind of buried it back then. The oncologists picked it up in this big monster trial select selenium or vitamin E for prostate cancer prevention. Vitamin E was great. It was blocking cancer cells in culture. So they gave it to not 10 or 100 or 1,000 people like it was in Beaven's. They gave it to 37,000 people and followed them for more than 10 years. And you can see from the back of the room that there's a difference in those two curves. The problem is that the curve at the top shows that vitamin E actually, the people who got vitamin E got more prostate cancer, not less. So that's a real bummer, especially when you're talking to patients and I can tell them the Nash trial only lasted 2 years, and the curves are no different there. So if you keep giving vitamin E year after year, at some point the risk of prostate cancer is going to go up. Yikes. And the same is true actually for ischemic stroke. There's an increased risk, and we're talking about numbers in the hundreds of thousands have been looked at around the country. I'm just going to show you this to let you know that FXR, that receptor I told you about, turns out to be, when you tickle it, you get lots of improvement in glucose and lipid metabolism, and this is the pathway by which it's mediated. There's a secondary receptor for bile acids called TGR5. It seems to be a minor player, but it's a real stick in the mud for people who perform FXR studies because they always have to worry about off-target effects of TGR5. Turns out obeticholic acid only tickles FXR. And in a nice paper this last year, these guys showed that if you remove FXR, you no longer get the beneficial effects of bariatric surgery. So it is an FXR-specific effect. So somehow, bariatric surgery is actually working through the FXR bile acid axis. So let's talk about the Flint trial. The Flint trial has been much anticipated for several years. It's a double-blind RCT in patients with biopsy-proven non-cirrhotic NASH. They got treated with drug or placebo for 72 weeks, and half the patients had diabetes. So the good news was they had improved NAFLD activity scores, if you care about NAFLD activity scores, and a trivial improvement in liver fibrosis. But complete resolution of NASH did not differ. AST/ALTs improved during treatment, but not afterwards. And the real problem is that there was a 23% rate of significant pruritus. Think about that. You've used ursodiol to treat pruritus in the past. Now here's another drug in reportedly the same class that's actually causing worse pruritus. They also have increased lipids, and there were 2 deaths in that trial. So obeticholic acid, the data are mixed, and I think it's probably not going to be used in large amounts. All right. So the end organ effects in chronic liver disease, you're probably familiar with a picture like this. We think of NAFLD as being sort of the benign form of fatty liver. And you can maybe oscillate, have some abnormal liver tests and injury, but usually your liver's tough and can sustain itself. In the face of chronic inflammation and oxidative stress, you probably develop chronic fibrosis, which we call NASH, and that's what leads to cirrhosis. But we don't know the natural history of that. We don't know who's going to run into trouble from it. I've got lots of thin patients with horrible NASH. I've got morbidly obese patients with normal liver tests and minimal steatosis on imaging. And of course, the upshot of getting cirrhosis is the risk of getting liver cancer, dying, or needing a liver transplant. So the question is, even if we treat all this stuff, can we reverse Mr. Ronald McDonald from his state of fatty liverness? And the answer is probably with bariatric surgery. That's our best bet. It's still our best bet. Because the outcomes are horrible, right? 300 million people in the country, and even if you use a conservative estimate of about 5% NASH prevalence, you're still looking at 17 million folks. Now, if you're super conservative and go by autopsy series, there's only a 1% NASH rate in autopsy series. But if you look at the right-hand column here, where I'm showing you cirrhotics, liver-related deaths, and hepatocellular carcinoma, you would still end up with something like 30 to 60,000 hepatocellular carcinomas with the most conservative NASH prevalence. How bad is that? Well, there's only 5,000 to 6,000 liver transplants performed a year in this country. Now, hopefully we're going to stop doing transplants for hepatitis C because we're going to get rid of it. But there's lots of other reasons to need a liver transplant. So we cannot possibly use our entire supply just for this. And this little graph, the little red arrow, shows you by different causes of liver disease. It used to be hepatitis C over there on the left. Most of the transplants were from hepatitis C. They're all stable or decreasing. And the rare causes on the right, the autoimmune diseases, are actually going down. But fatty liver, cryptogenic cirrhosis, and NASH is the only cause of chronic cause for liver transplant that's increasing. It's a true epidemic. And it leaves us with the elephant in the room, which is, of course, HCC. So several of us now believe that we need to be screening people before the cirrhotic stage for liver cancer. At least once every other month, I get somebody whose presenting symptom of the metabolic syndrome is HCC. And it's usually picked up because of a different imaging study. So it's really scary, and we don't have ways to properly define what bins to put people in, which argues that you shouldn't necessarily be putting people into bins. You should be looking at ways to reflect the biology that's going on, which implies you understand what the biology is that's going on. So NAFLD is like a benign little brownie. He's happy, probably not going to hurt you. But he's like a Jekyll and Hyde, and he can turn into that nasty hobgoblin on the right, which is Nash. And I want to leave you with the idea that metabolism is a key driver of insulin resistance. Inflammation is an important modifier or propagator, but it's probably metabolic changes in different organs that differ for different people because of their underlying genetics. There are still no good medical therapies for Nash. Do I use vitamin E? Once in a while I do, but I do it with the caveat that I know that if I keep somebody on it for 8 years, I might be inducing a risk for prostate cancer or hemorrhagic stroke that I may not want to take on. So it kind of depends where I think somebody is in the disease spectrum, and if they have advanced, if we might stage them with a liver biopsy, and if they have advanced disease, we can have that talk around vitamin E and even pioglitazone, which I use in my diabetic patients. Bariatric surgery, I'm a medical doctor. I don't cut people open for a living, but the data are very clear. Bariatric surgery is a great resource if somebody's a candidate. So morbidly obese, that gets you a Medicare approval. BMI of 35 and above with a complication like dyslipidemia, diabetes, and a couple others, including sleep apnea, can make you a candidate for it. You can pay for it out of pocket if you're between BMI of 30 and 35, but we're not quite sure whether we're willing to take on that risk or that number of people at this point. The outcomes of NASH are ominous because of the risks of liver cancer and just the simple burden of disease. So I just wanted to leave you and let you know that we have at UCLA established as of a couple years ago a program called the COMET, which stands for the Center for Obesity and Metabolic Health. And the idea is that we're going to create a center of excellence to understand this type of disease and metabolism and improve the lives of generations of patients. I think rare diseases are great. We can learn a lot, but this is truly the health epidemic for the world for the coming century. So a lot more people need to come study it. And so we're interested in the interrelationships between the liver and the other organs as they progress towards diabetes and cardiovascular disease. And I'll tell you about, when you see slides and presentations on liver fibrosis, whether it's Hep C or Nash, you're used to hearing about staging systems. Stage 1 is okay, stage 2 is not so good, stage 3 is bad, stage 4 is cirrhosis. And those staging systems have been used, and there are a lot of underlying assumptions about what they reflect. We have actually developed a novel tool that doesn't require a human to look at a biopsy slide. And what I'm showing you here is a high-resolution scanning of a Nash section. You can see all that fatty bubbling in there, but there's all that red stuff, which is scar tissue. Pathologists hate to sit there and look at that red stuff and go, I don't know if that's a 1 or a 2. I don't want to split that hair. Hepatitis C is actually fairly straightforward. You can, with a few training slides, you can look at a set of hepatitis C slides and go, that's a little, that's more, that's a lot, and that's cirrhosis. It's all nodular. NASH is very wispy. It's very diffuse. And so, in fact, trials like the Flint trial did not emphasize fibrosis. They're very happy when they get a fibrotic outcome, but their main clinical outcome was actually an improvement in their NAFLD activity score, which is a measurement of how much steatosis is on that biopsy, how much hepatocyte ballooning there is, and how much inflammation there is, not the amount of fibrosis, which we think is really the constricting and damaging part in the long run. So we defined this tool that actually scans this using digital imaging, and on the bottom right, you can see the computer has identified, it's really in black, the small wispy stuff. It excludes the large perivascular collagen and the capsular collagen, so it doesn't overestimate. And we've tested it against a couple of our pathologists in a blinded fashion. We have some intellectual property interest on that. But more importantly, we have applied it retrospectively to more than 400 patients, about 125 with hepatitis C, the others with Nash. And it's very clear that the progression of fibrosis in Nash is totally different. In Hep C, it's sort of linear. The Medivir score makes fibrosis percentage go up like that, linear. Whereas in Nash, it's flat, 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 and then there's a sharp uptick. So again, non-invasive markers, blood tests are probably going to be useless. And we think this approach is really giving you the answer to the question of what is the maximal amount of information I can get from one of these precious liver biopsy slides. Because I don't want to go out and biopsy everybody. I want to do it in a controlled fashion and figure out what it means for different people at different times, though. So our current projects, we have an IRB approval. We're enrolling patients. We're following them for 2 years. I invite you. You can come find me. I've got my card. We want everybody. We want the bariatric surgery patients. We want the abnormal liver tests. We want the simple fatty liver. We need all of it, because what we need is to find good and better biomarkers. And that means blood, and that means genotyping. So we have an interest in the genetics of liver fibrosis, the regulation of intestinal lipid metabolism, the role of ribose, which is the second most common sugar in your bloodstream. You probably didn't even think about ribose. And CNS changes, central nervous systems changes that happen in the setting of bariatric surgery. So I'll just leave that up there. That's how you can contact us. And thank you for your attention, because hopefully one of these years I'll get up here and say, we've got a great new drug like Harvoni for hepatitis C. But this is not that year for Nash. Thank you.